Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to Health Matters. Our studio and guest tonight is actually known to the viewers. She's one of our resident and regular radiologists and a super specialist at mammography and bone density, and that is none other than Dr. Nadia Jajbhay, who will be speaking to breast cancer today. Welcome, Dr. Nadia, and I think I would like to also take the opportunity to introduce your area of expertise to the viewers. But before we proceed, I'd like to begin with a tarbiyah. A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Healing and treatment from Quran and Hadith. Quran is a miracle that Allah revealed to His Prophet, peace be upon him, and it is a blessing for humanity. The Quran is not only a guidance for mankind, but Allah has made it a spiritual cure and healing for all types of ailments. This includes treatment of all worldly problems, physical and psychological ailments, and spiritual. The Creator has told us that the words of the Quran are a shifa, healing for all, and therefore, when used with real belief in one's heart, this form of treatment can bring miraculous cure to all forms of ailments. Allah says in the Quran, وَنُنَزِّلُ مِنَ الْقُرْآنِ مَا هُوَ شِفَاءٌ وَرَحْمَةٌ لِلْمُؤْمِنِينَ. And we send down of the Quran that which is a healing and a mercy to those who believe. As for other forms of treatment, Islam does not discourage the use of treatments available to us through medical and other sciences. On the contrary, the use of such treatments is encouraged by the teachings of the noble Prophet, peace be upon him, who sought the treatment of illnesses and diseases for himself and urged his followers to do the same. Thus, seeking medical treatment for the cure of diseases is part of the Prophet's tradition. Sadaqallahul Azim. I think we would like to now continue with Dr. Nadia Jajbhay. Once again, a warm welcome to you. You are one of our most favored and favorite experts on the program, and I think the viewers would agree that they've enjoyed the program, and we look forward to this program and topic on breast cancer. Now we know that it's Breast Cancer Month, and a lot has to be said, a lot has been said, but we'd like to give you the platform to open up this discussion.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for having me. Bismillahir Rahmanir Rahim. Rabbi shrah li sadri wa yassir li amri wahlul uqdatan min lisani yafqahu qawli. And that excerpt that you opened up with about the Quran being, a cure and a healing, we have to keep at the center of our advice when we are treating patients, because this is divine healing. Yes, it's a Breast Cancer Awareness Month, and Alhamdulillah, we've come to a time in awareness about our own health and women's health that more and more women are acknowledging the breast as an organ to be aware of. Younger and younger women are coming to my practice with breast pain, with lumps, and are a bit more open to discuss it, because there has been this worldwide, not only nationwide, but worldwide awareness about breast health and breast cancer, unfortunately. we still have a lot of challenges, because in our country specifically, where we haven't reached all the outlying areas and the impoverished communities that still need awareness, but on a global level and a nationwide level, there has been increase in awareness, and all of us in our own capacity need to bring it forth that women need to be aware of their breast health from the time of maturity when the breasts are developing, and awareness of breast cancer itself being now a terrible disease, specific now, increased in our times.
So,
Okay.
Dr. Nadia, I think just looking at what you've highlighted, that this is a global problem. It's not just a national challenge or scourge that we're faced with. If we look at the statistics, the incidence and prevalence, what would you say? How many persons are affected by breast cancer?
All right. So statistics are a difficult thing to actually discuss, because our nationwide statistics are not updated. I'll quote to you what we are given in the literature. So if we look at now you obtain Professor Google, or you open up a book and you say, okay, what is the prevalence of breast cancer worldwide? In the first world, and so in the US, it's quoted, because these are American statistics. They will quote a blanket stat of 1 in 8 women that are affected by breast cancer. If we look at our local statistics, and I'll tell you why there's a lot of problem with our local statistics. Our local statistics, if you do it and you Google it for South Africa, or you read up the literature, and there's specific research articles that are specific to breast cancer and in the last 4 or 5 years, okay? They quote something between 1 in 22 to 1 in 24. Now, I'll tell you why that's a problem. The problem is, they tell you that the population that was researched was a closed population. So we're not looking at something that's representative of the entire South Africa. What about those women who didn't come into hospitals, that died at home, and often they die in stage 4 cancer, so they don't know the primary, that it could have been breast. Okay, so those that are reported, so there's a problem in reporting.
Yes.
And then those patients already in hospital, and then the dilemma of, like I say, still finding the primary. I still till today will find some patients say, Granny died of the liver cancer. So I said, liver cancer is not a common thing. It's not. It's often one of the common sites of metastatic cancer. And in women, top now, unfortunately, as we're speaking, worldwide, and it's becoming our local problem, is breast, cervix. For a woman, we have to worry about colon cancer and lung cancer. So these are the top 4. If we are Caucasian, then we have to add skin cancers as well. Okay? So this breast issue, and I will say, but where did this come from? Because we didn't hear about it yesteryear. Where does this breast cancer come from? Why is it so common nowadays? I think it's twofold. First of all, we are finding and we are diagnosing that truly this is breast cancer. It's not somebody who just died of unknown causes, unknown primary, because there's earlier detection with better technology, more awareness, more people coming in. Okay, so that's the one fold. But there's definitely a lifestyle, but there's a general carcinogenic type of lifestyle that we are living, and there's a big unknown. We have to admit. What we know about breast cancer is X, where less than 10% genetic risk, about 40% in the lifestyle range, and I'll tell you why we're predisposed to it. And then there's a whole 60%, so less than 40% in the lifestyle. There's a whole about 60% that is unknown, that's still being researched. Is it stress? What happens when we we stressed out? What type of hormone? What about all these other substances? People are talking about doing a Brazilian haircut and hair treatments, and then certain makeups and this methyl parabens, all these carcinogenic substances that could potentially be players in this.
So you speak about a lot of risk factors, contributory factors. I also want to check out with you, what is the high risk age cohort that it is most prevalent in?
All right. So yesteryear, they would talk about women above 50. Okay. Definitely age is one of your main risk factors. Now we're finding it earlier. Why are we screening from 40 onwards? They're using 45 now and up. Okay, as far as where your risk curve goes steeply high. Unfortunately, we're seeing younger and younger women now with breast cancer. In my practice, I've seen many women in their 30s, which was, previously unknown. There are quite a few in their 20s. Okay. It becomes rarer as we become in a younger age. Like you say, as we age, that's one of our main risk factors. Okay. Another thing we can't affect, so there's certain things we can affect as our risk factors, our lifestyle things. Some things we can't affect. The density of our breast, this is a term radiologists have coined, because it's a description on the mammogram, and this is how we screen for breast cancer. So density of the breast is the thickness of your breast tissue, and it represents the amount of milk tissue as opposed to the fatty tissue in your breast. Now, women who have dense or this thick compact tissue, and we take it at the age of 50, at menopause or later, are 5 times at a higher risk than those women who don't have dense breasts. And that you cannot affect on the whole, because often it's genetic. Sometimes it's from long-term hormone use, okay? The ones that the patient group that can affect it are those who are in the obese group. So there's obesity, and that's why there's density. There's extra estrogen in the system, and that's why we can affect it. Or those on long-term hormone replacement therapy, they can affect it by then tapering and having advice how long to take the HRT, etc. But on the whole, it's a genetic thing, so that we cannot affect. And those are the two main. You can't affect your age, your density, and the genetics is less than 10%, like I say, if that's inherited.
So we'll take an ad break, and we'll continue with the discussion after the ad break. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters. For the viewers that have just tuned in, we have our guest, Dr. Nadia Jajbhay, who is known to many viewers out there, who is a radiologist. She's been in the field for more than 10 years as a specialist, and her area of speciality is mammography and bone density, and she is speaking to breast cancer. As we know, it is Breast Cancer Awareness Month. Now, we were speaking earlier on about the high-risk age cohort, and during the course of the discussion, you mentioned that you've had patients as young as in their 20s. What would your recommendation be to people out there? When should a person start screening or examining their breasts?
All right. That is a very important question, valid question. So let's talk about examining the breast. That's different to the screening of the breast, right? So examining the breast, the moment a young girl goes through puberty, and we call it telarchy, when the breast buds are forming, okay? And that's, it ranges between, now younger girls, they are younger and younger as they start their period and developing the breast. So the moment telarchy happens, they are developing these breasts, breast examination should happen. So moms should advise their young daughters, the moment the breast buds are there, they should gently feel it, and if there's any problem, they should mention and have it seen to. Our breasts mature at age 21. When I say mature, the full complement of breastfeeding tissue achieves maturity at age 21. So from then, the recommendation is that a medical doctor, a clinical examination should be performed yearly. So clinical examination is your GP, your gynae, a trusted doctor. Before it wasn't happening because there weren't many women in the field. And as a young person, you are very shy just to expose yourself for anyone to do an examination. Also, we had these barriers in our homes as to would we talk about the breast? Did we touch our breast? Did we check our breasts? So clinical examination, nowadays, because there are practices like myself where we are doing ultrasound, the young girls are coming through much earlier and saying, you know, I felt a lump, or I've got a lot of pain, or there's an underarm lump. All right, so we're talking about clinical breast examination. Then there's the self-examination, which I just touched on to say that monthly, a week after the period, we must be checking our breast and being aware that this is how it normally feels like. If there's a problem, we're able to then report it to our loved one who will take us to a doctor to have it checked out. Now we talk about screening. So screening is, I'm otherwise well, I don't have a complaint. However, I'm now presenting myself for early detection of breast cancer. So in the normal population, non-risk population in South Africa, we're doing the first mammogram at 35. If you haven't done it by 35, you'll do your first one between 35 and 40, right? So it's a first screening mammogram. And then from 40 onwards, we're saying annually. Then comes that whole fight with the medical aids are saying, no, we'll only pay every second year and you must only do it every second year in your 40s. Our protocol in South Africa is annually, and that's for the chance for early detection. And that goes towards our general population, not risk population. From 50 onwards, there's no discrepancy. Whether it's a first world, a third world, worldwide, we're saying strictly annually for early detection of breast cancer. Okay? Now, this high-risk group, and there are specific women are in this group where you either have high risk because there's a strong genetic risk, so you have either 2 first-degree relatives or first-degree, second-degree, third-degree relative, or there's some strong genetic risk or there's strong lifestyle risk. In these patients, we are screening earlier. So then you say, but when? At 30, when? So we avoid mammography before the age of 25. We will only use it not to screen, but to diagnose. So a patient comes in and then they're in this high-risk group, we can do one to diagnose, but that is few and far between. The rule of thumb is, so just say mother was diagnosed at age 35, right? That's a bad number I just realized why. We will minus 10 from that number and start her screening at 25, okay? Her screening should be tailored by somebody in the know. So if she had come in to me, we would say, look, you're a young woman, still very dense tissue. I would examine her, do the ultrasound first, and then decide if I'm going to screen her with the first mammogram or I'll send her for an MRI scan, because MRI scans are used in younger population where it's not advisable just to put through X-ray radiation. So really that's the rule of thumb, by minusing 10 from the youngest age of the diagnosed relative.
So if there's any familial history, then
familial history. So that lady is high risk. Then there's lifestyle risk. So women who are in the high lifestyle
high
risk
lifestyle
group.
Yes.
So they are women who haven't had children before 30. Women who've used fertility treatment, more than 10 years of oral contraceptive, okay? But these are few and far between.
And does HRT fall anywhere between that?
Remember, HRT is now in the postmenopausal group. So they're still already in the screening age group. They'll already be doing their yearly mammograms in that age group, okay?
So the other question is often, I think there's a misnomer, misperception that breast cancer affects females only.
All right, so anyone who can develop breast tissue is prone to breast cancer because that's our tissue of origin, and men can develop breast tissue. It's a condition called gynecomastia, okay, and there are risk factors for that. But the statistic of what the prevalence is 1 in 100, okay? Men do develop breast cancer. Nowadays, because we are having earlier detection of prostate cancer, okay, and those males requiring hormone therapy for prostate cancer, they develop breast tissue. So we've got certain groups of men who are now in the higher risk group, okay. Any testosterone dysregulation with gynecomastia. Now with HIV being treated on ARVs, it's also ARVs can cause gynecomastia, okay? There's definitely a genetic risk with men as far as breast cancer. Breast cancer, there are many well-known genes. The two very well-known ones that were studied in Ashkenazi Jewish and the Dutch population are called BRCA1 and BRCA2. BRCA1, the breast cancer gene 1, and breast cancer gene 2. And they overlap with other different cancers in the genetic DNA sequence. So it can be colon cancer, pancreatic cancer. The other one is with ovarian cancer and melanomas. So if this is passed down in populations, men can get it genetically as well. Okay.
And what would your recommendation then be to men? When should they start screening?
You know, men don't screen for breast cancer.
Yes.
So I would advise, and this is where the holistic management of a patient comes in. And this is where the awareness for everybody, not us women, it's an easier concept for us to screen. You know, there's nothing wrong with me, but I present myself to a doctor for a test. For a man, for most men, there's a generalization. So not all men are like this, especially in this day and age. There's much more awareness. But let's generalize a little bit and say, compared to women, men don't see the need to present themselves to a doctor in a hurry if there's nothing wrong with them, to screen. So the recommendation is to our medical fraternity that men in the risk group should be identified. And out there, the awareness for men is not only towards prostate and testicular and lung cancer because of smoking and colon. These are the 4 big ones for men, right? Bladder also included. Awareness needs to be put and targeted. The pink ribbon should move across to men too and say, look, you know, you can also. And there the onus is left to referring doctors to say, look, you know, I can feel something physically, or because you've developed breast tissue, now you're at risk, you need to go through, because you're on hormones, please go through and present yourself for a mammogram. So there are no definite guidelines for men.
Okay. So just a word of caution to men. We're taking an ad break now, so
Yes.
we've got like 30 seconds. What would what would you say to men out there?
Your general health is so important, and the screening concept needs to be embraced. If there's any breast tissue formation, you need to present yourself to a doctor and be aware that you might be asked to do a mammogram and an ultrasound, and make yourself aware for yourself, not only for those loved females in your life, but for yourself as well, to present yourself to have an examination.
Thank you, Jazakumullah khair. We'll take an ad break now and continue with Health Matters after the ad break. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters. Our guest in studio tonight is Dr. Nadia Jajbhay, who is a radiologist in practice, and her area of expertise and special interest are breast cancer and bone density, so mammography and bone density. And we've been talking about breast cancer as it is Breast Cancer Awareness Month. Dr. Nadia, we were talking, and you included men. You said we cannot be exclusive. It's not just a female afflicted illness or disease, but it affects both genders. Now, in terms of signs and symptoms, what would you like to alert the viewers on breast cancer? What is it that they should look out for in terms of signs and symptoms?
Okay. Here is where we encourage everybody to be self-aware. Breast aware means that I also examined my breast tissue. So we tell young women, like when I mentioned, as the development of the breast, we're going to do our self-examination the week after the period, because it's the least sensitive time of the month. Okay, otherwise everything feels lumpy and sore, and you're not sure if it's pathological or not, and yet it's just consequent to your cycle. And the signs and symptoms you're looking for as a woman when we are doing our breast self-examination is texture of your breast. Texture is very important. So most women say, but everything feels lumpy and bumpy. How will I know it's a lump? Well, you've been doing it every month. You know what your normal lumpy texture feels like. Okay, and you're not feeling it at that sensitive time of the month. So anything new would be a textural hardening or thickening of in feeling. And trust your sixth sense, because you know yourself then if you've been checking regularly, okay? And you should be doing it in the shower, or in the bath, a bit of shower gel or soap on the hand, and opposite hand to opposite breast, feeling with a flat hand, not poking, not pulling and pinching, because when we pinch our breast, we're going to feel the actual breast lobules.
Yes.
Okay. The underarm is a very important area to go from, all the way from the underarm towards the breast and behind the nipple. Okay. So we're feeling the texture of the breast. We're also feeling for any pain. But now you're going to say, but isn't most breast cancers are not painful? And that is correct. If we're feeling pain, we need to know, is this the time, is it related to my time? Did I just finish a period? Or pain can be from cysts and other types of lumps. Some breast cancers can be painful, but not on the whole. Okay, but we're feeling now, and we're feeling anything that is out of place. So when we're feeling, that's what we're feeling for, texture, and we're feeling for lack or presence of pain. Then we're also looking, so then a lump in the underarm. So a lump can be hard, gritty, it can be fixed or mobile, it can move around. And typically these common lumps, what we call fibroadenomas, which are more common in the teens and 20s, but can happen throughout our reproductive life, okay? Feel like a marble or a hard marble. They call it the breast mouse because it moves around.
Okay.
It doesn't move from one part of the breast to the other. It's just not fixed in the tissue and hardened. So we're feeling for that. Looking is very important. So you must look down at your breast and your bra for certain things. So you're looking at the skin and the appearance of the nipple, the symmetry of your breast. Was this one always bigger than this one? And most of us have one that's slightly bigger than the other.
Asymmetrical.
So asymmetry, right? And then we're looking at the skin and the position of the nipple. Was it always flat? Are my nipples flat? Are they inverted? Do they go in? Is this a new thing or not? Okay? And then we're looking at our bra for any discharge. We're not squeezing on the nipple to check for discharge. If we do that, we're going to induce a discharge. Most of us have secretions in our ducts, and they will come out when we're not breastfeeding, okay? And we're also noticing the skin. We're looking for rashes. We're looking for pimples. We're looking for redness, swelling, something that's amiss.
So discoloration?
Right. Yes, discoloration. Now, you mentioned about men. So what are they feeling? Because it's not their time of the month. So for a man, they will be in there quickly to a doctor if it's gynecomastia. Okay, gynecomastia is not a cancer. It's the development of breast tissue. So they're not used to sensitive tissue in the chest area, and when it develops, they are very, very aware, and it's painful. They're not used to this, the sensitive tissue. So they gently feel with the flat fingers on the chest, and if it is lumpy and nodular in that area, they have to have it seen to. They're also looking for asymmetry. They're also looking for color. They're also looking for discharge coming out, all of which can happen because of the breast tissue. Underarm for lymph glands again, okay? But I want to say here, this is where the breast awareness, and this is where people like ourselves, or we spread out that message out there of the awareness, is that we are praying you don't come into us with a symptom. This is what the beauty of screening is, because you're coming in, you're otherwise well, you have no complaint, and we're looking for early detection of breast cancer. Early detection of breast cancer is when we look at the mammogram and we're finding pre-cancer. We're looking at ductal carcinoma in situ that's going to become breast cancer. Okay, so there you'll have no symptom. You can't feel them. We won't be able to feel them physically. On an ultrasound, we don't even see DCIS. DCIS is only picked up on the gold standard, which is the mammogram. And these are these little microcalcification clusters that we can see on the X-ray. Okay? We're hoping to find early stage where you are already, there's no lump, there's no discharge, there's no skin discoloration, there's no powder orange. Powder orange is that swelling when it becomes so spread up to the level of the lymphatics, so your lymph, and to the skin level, it looks like the orange peel. So they call it powder orange, okay? So breast cancer, we're trying to find stage 0, which is the DCIS, stage 1 or stage 2, under 2 centimeters of something. Maybe you have a very large breast and you can't feel to the back, and we're finding it on the mammogram, okay? By the time somebody is already symptomatic and they come in, and now we're doing a diagnostic mammogram, we're not screening you, we're now looking for the diagnosis and trying to say, is this breast cancer? Is it a fibrous lump? Is it just thickening? Is it scar tissue? Then we're likely to be dealing with more advanced cancer, the stage 3s and the stage 4s. The problem with that is it's so much more difficult to treat. It's not impossible. With the advent of better treatment modalities and chemotherapy and radiation and different surgical procedures, you can have it treated, but it's a fight. It's a fight for your life, number one. Number two, the recurrence rate is so much higher. And then, the textbooks give you those horrible things called 5-year survival that completely drops once we're dealing with stage 3s and stage 4s. Okay, whereas when we're dealing with stage 0, 1, and 2, they quote the 5-year survival up to even, they used to say 95, now they're saying 98%. Okay? There, I just like to just divert a little bit as a Muslim woman and say, I'm a medical professional. I don't like to talk about 5-year survivals and prognosis, because it's such a multifactorial thing. And we believe in Allah subhanahu wa ta'ala. We believe in other methods of healing, and that is your strong conviction to fight and survive. We believe in support systems. We can't look at the body as a physical entity. We have to look at it holistically. We are spiritual, emotional, psychological beings. And when somebody who's been given a diagnosis has the fight for survival, they've got support system, and they use whatever means, and they believe in the means, that is so powerful to healing. Whereas I could give somebody and say, look, you've got such a easily treated cancer, and they've lost hope in life, and they don't have a support structure, and they don't really believe in the treatment. How well do you think their immunity is going to fight that?
Or respond to it, yes.
Any disease this goes with, not only cancer.
We can continue this discussion so much longer, but I think we have to touch on the treatment, the radiation and other forms of treatment of cancer. Perhaps you could speak to the viewers about that as well.
All right. So the treatment of cancer is really specific to, we definitely look at age. What we might tell somebody before age 75 and with other medical conditions, we might not say, to a younger person, their resilience, their ability to withstand therapy. Okay, because I mentioned chemotherapy, mastectomies, radiation. It depends on the staging of the breast cancer. How early did we find it? In earlier cancer, more conservative breast surgery is can be done. Reconstruction surgery at the same time to match both breasts, because we're also looking at the aesthetics of, because we are holistic beings, we also how we're going to be seen from outwardly after our treatment. And then the need for chemotherapy is dictated by staging and spread as well, whether it's spread to lymph glands or not, but also the types of cancers. Certain cancers being more aggressive, chemotherapy might be prescribed. Also, there are different types of very aggressive breast cancers, like triple negative disease, as well as Herceptin positive cancers.
So
and
we've
those are
got
specific
30 seconds now, and
Yes.
we'll continue with the next ad break. But if you can just wrap this up quickly, and then we'll continue.
All right. So just in a nutshell, before we go into it in detail, is that it's really staging specific. It's also patient specific. So the doctor will look at the medical wellness and the age of the patient, how well they are to withstand therapy.
Okay. We'll take an ad break and continue with the discussion after the ad break. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to Health Matters, and this is our last segment, and we're discussing breast cancer. Dr. Nadia has been sharing a lot of information, and I think it's been very meaningful. Coming back to the interventions, the treatment, you spoke about aggressive forms, you spoke about the chemotherapy, radiation. If we can just continue with that, and then of course you can summarize what we've gone through from the previous segments.
All right. So important when therapy is being prescribed, we're looking at, first of all, the type of breast cancer we're dealing with. So when we biopsy a patient, we send it off to laboratories, and the pathologists give us an information very specific to that type of cancer, because there are different types. And we have to put it in perspective of the type of breast cancer. So there's certain aggressive types that are probably going to need more aggressive therapy, which include the triple negative types of breast cancer, Herceptin positive cancers, and lobular cancers. Lobular cancers being the more rarer type, and it's come from the supportive milk producing tissue in the breast rather than the duct tissue, which is the more common type. So it's a type of cancer. Then we send, once we've made a diagnosis, so we biopsy the patient, and we're saying what type of aggressivity or non-aggressivity of the breast cancer. We send the patient to a holistic team. So there'll be an oncologist, a surgeon, radiation oncologist, psychologist, etc., etc. That is, the purpose is for staging. So we're trying to see, okay, we found your breast cancer. Has it gone to the via the blood to any distant organs? So we're talking about metastases. Has it gone to lymph glands? So are those involved? So it's part of the staging. And certain tests will be done. So an X-ray, abdominal ultrasound, and a bone scan for metastases will be checked. Blood tests also be done. Staging will then allow the oncologist to advise what type of therapy. And I mentioned to you that the earlier staging, stage 0, often just need lumpectomy, often get away without having radiation. And then they take tablets like tamoxifen, which then are oral medications that actually blunt the estrogen effect. over a period between 5 and 10 years. Okay, so that will be in the earlier detection, where there isn't spread. Once there's spread, then there's the involvement and the tumor or the cancer is larger than 2 centimeters and there's involvement of the lymph glands. Then likely that mastectomy would be considered, likely that chemotherapy is going to be considered, likely that radiation is involved when we're staging in more advanced stages, number one, where the cancer cannot be taken confidently within 5 millimeters of normal tissue. So then radiation has to be taken. And there are different tools that oncologists use and surgeons use to be able to advise whether chemotherapy and radiation need to be taken in those borderline cases. And there's a test called Oncotype DX. It's all these DNA testing. There are different ones used in Cape Town. Sometimes they send them to the US. And depending on how aggressive, whether they're low grade, intermediate grade, or high grade type of cancers, whether chemotherapy needs to be used or not, and radiation as well. Okay.
So, summarizing what you've shared with the viewers from the first segment, what would your take-home messages be to a person out there, in terms of prevention, intervention, and seeking attention or getting support, immediate support?
Okay, so I think what I'd like to just mention are the common things that I see in my patient population that is common to most of us women, and I'll add a message for the men as well. I think what keeps us from, and I think it's any aspect of our life, keeps us from going to doctors, specifically when it's related to breast issues, is the fear. Here, ignorance is not bliss. So us being fearful and keeping ourselves back from having it seen to is not a good idea, because of what I explained. The more advanced disease there is, and it now being very common, earlier detection, you're giving yourself the chance for earlier detection by going in and having it examined and going in for screening mammograms. The other myth that I have to demystify is I hear a lot of patients still have it because they've read certain journals and so forth, is that, oh, well, regular or the annual mammography is going to give me breast cancer. If that was the case, we would never have screening protocol like that. The benefits of any modality and even prescriptive medication, the rule is the benefits of what you're taking or what you're prescribing, and here you're prescribing a radiation dose, has to outweigh the risks. The benefits of mammography completely outweigh the risks.
Yes.
The radiation risk is minimal. Taking a flight from Johannesburg off to Cape Town and the environmental radiation is greater than what you will get locally to your breast in a mammogram when you present yourself. And nowadays, with the digital technology that we use, the radiation risk is even lower. So there haven't been statistics where we say, oh, X amount of people got breast cancer because they had constant mammography. Yet, yes. How many women have benefited from early detection? And that's where we've weighed it out, and that's why the protocol is they said that annually you're giving yourself the chance for earlier detection. So we need to combat our fears. Ignorance is not bliss. We need to do self-examination. We need to present ourselves for screening mammography so that we're giving ourselves that chance and not waiting for a symptom and then it might be too late. And just as a general advice, and I advise myself too, is that we all want to live fruitful lives, quality-filled lives. And without our health, how much can we do? So we pray to Allah subhanahu wa ta'ala to bless us with good health, but we also have to, in tying our camel, do our utmost to inform ourselves about the facts related to our issues, our health issues. We have to embrace a healthy lifestyle. And when it comes to screening, we must be open to screening as far as going out and doing things like mammography, pap smears, etc., for our health. For the men, Screening is important as well, not only for prostate and other cancers, but also to present yourself if you do have a symptom. And if you are in a higher risk group, inform yourself whether you do need a mammogram or not. And there used to be a time where there weren't dedicated facilities that dealt with this type of issue. Now we are blessed that we run these dedicated facilities where we concentrate on these health issues. And women mustn't be, women especially who are so frightened. It's part of our aura, it's part of our personal parts, our private parts. And we're so sensitive about just exposing ourselves. There are facilities where it's done in dignity, where we can present ourselves to female practitioners to actually find out what is going on.
So what I like what you're saying is that we as people have the power of choice, and it is our responsibility to take charge of one's health.
Yes.
That each and every one of us need to assume that responsibility. And it's obviously what you highlighted earlier on about self-examination and seeking out medical attention. When in doubt, always seek out the professional and get the necessary expert interventions and take the necessary measures to ensure that it is detected early and treated early.
Yes, I think the most powerful spokespeople for the awareness in the breast cancer campaign are actually the survivors. We're so blessed to have survivors. I mean, you know, just the other time, just yesterday, I would use that word, you know, I mean, cancer really was a death sentence. Now women are surviving it. And they all, most of them, besides the first fight of getting through that first year of survival, where they are undergoing therapy, beyond are positively affected and value their lives and their health better.
And they're living a positive life, they're living a healthy life. I think what you just identified and highlighted is from victim-patient mode, surviving that disease but becoming a thriver. It's from patient survivor to thriver, and people are living healthy and living a positive life. So we have come to the end of our program, and I would like to take this opportunity to express our deep gratitude to you for enlightening everybody out there on the importance of screening, and that there is hope if people detect it and identify it earlier. So shukran dalilan, Dr. Nadia Jajbhay. I'm sure the viewers would agree that it was absolutely informative and enlightening, and hopefully people out there will respond to it and ensure that they get the necessary screening as soon as possible. On that note, I'd like to end with a verse from the Holy Quran. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والأسر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. صدق الله العظيم. Until health matters next time. Assalamu alaikum wa rahmatullahi wa barakatuh.